is there a conversion that takes place in the mouth by these bacteria that makes production of nitric oxide much more efficient?
Yeah, so inorganic nitrate, which is NO3 minus, is completely inert in humans. Humans do not have the machinery to metabolize this enzyme or this molecule. So the bacteria do. There's nitrate-reducing bacteria that perform this 2-electron reduction of nitrate to nitrite. And so that actually provides then saliva that's enriched in nitrite. So when we eat, I'll show you how this works. So if you eat a plant-based diet, so let's just say we eat 150 grams of spinach or kale, 90 minutes after we consume that meal, that nitrate is concentrated in our salivary glands. And now each time we secrete our saliva for the next 6, 8, 10 hours, we're secreting nitrate. And then the nitrate gets in the crypts of the tongue. It's metabolized by these nitrate-reducing bacteria to now form nitrite in the saliva. And then now we have saliva that's enriched in nitrite. We swallow our own saliva. The pKa of nitrite is 3.4. So when you get this acid disproportionation of nitrite, it forms nitric oxide in the lumen of the stomach. And you can actually facilitate that and accelerate that by things like vitamin C and polyphenols that provide the 1-electron reduction of nitrite to nitric oxide. So the bacteria perform the 2-electron reduction of nitrate to nitrite that humans cannot perform. And then the stomach acid and the antioxidants, polyphenols, help perform the 1-electron reduction of nitrite to nitric oxide in the lumen of the stomach, provided there's stomach acid.
Exactly. So you have to keep your mouth as natural as possible. How does nasal breathing play a role in helping out with nitric oxide production?
Well, the enzyme that makes nitric oxide, the NOS enzyme, is found in our endothelial cells, and it's also found in our epithelial cells. In fact, the highest concentration of this enzyme is found in the nasal epithelium. And so if this enzyme is functional and coupled, when we deep breathe, when we do nasal breathing, there's mechanoreceptors on these epithelial cells that when they're activated through nasal breathing, through deep breathing, the NOS enzyme makes nitric oxide, and you can actually deliver nitric oxide to the pulmonary vasculature, dilate the pulmonary arteries, so you can get a better match of ventilation to perfusion, and then you can better oxygenate tissue. You get better oxygen uptake, and you get better oxygen delivery to the periphery. But if you have endothelial dysfunction, meaning that the enzyme is uncoupled in the endothelial cells, then you have epithelial dysfunction. So you can do nasal breathing till the cows come home, but if the enzyme isn't coupled and functional, you're not going to get any nitric oxide being produced. So we have to focus on the function of the enzyme and now teach people to do nasal breathing, because we need oxygen to make nitric oxide, and we need nitric oxide to uptake and deliver oxygen by hemoglobin in the red blood cells.
Do you have any experience or any information regarding glyphosate?
Yeah, so glyphosate does two things. Number one, it kills the oral microbiome just as it kills the bacteria in the soil when it's sprayed on crops. It kills the oral microbiome as well as the gut microbiome. But it also uncouples the NOS enzyme. So it kills the enzyme that makes nitric oxide, and it kills the microbiome that produces nitric oxide. So glyphosate, similar to proton pump inhibitors, inhibit nitric oxide production from both pathways. So if you're exposed to glyphosate, you've basically completely inhibited your body's ability to make nitric oxide.
We've talked about nitric oxide and how we can monitor its levels, testing, and you talked about that you have some nitric oxide products that can potentially make a change. Are there actually any studies that you can talk to us about what changes actually happened with these approaches?
So we've done a number of studies, both kind of in the nutrition dietary supplement space, and we've done drug studies in specific patients with specific disease indications. So it can normalize blood pressure. I've got a number of patents on these. So these are published, issued patents. It's a method of reducing inflammation. So we've shown that through our nitric oxide product technology, we can lower C-reactive protein, which is an acute phase marker of inflammation. We lower triglycerides by 30%. So two of my patents are on a method of reducing inflammation, method of lowering triglycerides, and then a method of improving athletic performance in mammals, so you can improve exercise performance. And then clinically, we had a paper in collaboration with Texas Children's Hospital in a pediatric patient population with an inborn error metabolism called arginosuccinic aciduria, or ASA. So their primary clinical problem is hyperammonemia because of the urea cycle disorder. But these patients they're born without an enzyme called arginosuccinate lyase. And this is part of the enzyme and the protein machinery that shuttles L-arginine and citrulline to make nitric oxide. So what we discovered, and we published this in Nature Medicine in 2010, was that these patients that don't have the ASL enzyme, the protein complex falls apart and they're completely devoid of any nitric oxide production. So they develop hyperammonemia, they develop neurological dysfunction, they develop kidney disease, resistant hypertension, and really systemic disease that couldn't be explained by the underlying inborn error metabolism. So we started treating these patients with our nitric oxide lozenge, and we could lower their blood pressure. So resistant hypertension, and in this one patient we saw, his blood pressure was 210 over 115, a 15-year-old kid, and there was no antihypertensive medication that would lower his blood pressure. So we dosed him with our nitric oxide releasing lozenge. Within 4 hours, his blood pressure was 130 over 80. We got him off all prescription drugs. His kidney disease resolved within 5 days. His heart disease resolved within 5 months.
Question.
Yes.
Question. Was this a repeat dosing or single? I'm pretty sure not a single dose.
No, not a single dose.
Yes. Yeah.
Yes. So we had to repeatedly dose this. And this is where, the best medical judgment of the physicians and the medical team come into play. So it's hard to prescribe a one-size-fits-all because everyone's different. But in this particular patient that's completely devoid of any endogenous nitric oxide production, he had to take one lozenge every 4 hours to normalize his blood pressure because he was completely devoid of any endogenous NO production. And so we dosed him according to normalization of blood pressure. So he was taking about 5 lozenges a day. But obviously that's not normal, but this is probably the best human phenotype of complete nitric oxide deficiency, is this rare genetic disorder. But we completely normalized this kid who had an inborn error metabolism with a nitric oxide releasing lozenge when all other prescription medication had failed him.
So we're talking about pharmaceuticals, right? So there are, I think you mentioned a few as well, Imdor, isosorbate dinitrate, and they sort of have a similar function. So what differentiates these lozenges from these medication already out there? And if somebody goes on a low dose of Imdor, perhaps, would that be beneficial for individuals, whether they have heart problems or not?
Yeah, so the things like nitroglycerin, isordyl, isosorbate mononitrate, these are called organic nitrates. And so they have to be metabolized into nitric oxide, specifically mitochondrial enzymes within cells. So, and there's known process called tachyphylaxis, which means that chronic administration of these drugs develop tolerance. So the patient actually loses their ability to metabolize these drugs into nitric oxide. And so you can only use these kind of episodically, and you have to wean patients on and off of this. And this is very challenging for cardiologists trying to treat patients with ischemic heart disease that have exertional angina, because you start to lose the efficiency and the efficacy of these drugs with prolonged use. And in fact, the long-term outcome studies have shown that people actually get worse. Outcomes don't get better on organic nitrate use. So there's a limit of clinical utility of these drugs. So what we do is completely different. We don't make organic nitrates, which is a nitroester bond to a glycerol backbone that requires some endogenous metabolism. We use natural product chemistry to restore, to make nitric oxide through the lozenge, but also some electrical potential and physical chemistry in that lozenge to recouple the NOS enzyme. So we get the opposite of tolerance. So we don't cause tolerance in these patients that take our lozenge. We actually improve the body's ability to make nitric oxide on its own. So it's completely different. And the beauty of this is now in patients that have been on organic nitrate treatment chronically for ischemic heart disease and had to wean off, then they're at risk for, heart attack or stroke. There's now an alternative to where, using the best medical judgment of the physician to start these patients on some of these nutritional regimens and now improve their body's ability to make nitric oxide. And I think for the first time in the history of medicine, start having the conversation of how do we start weaning patients off meds instead of putting patients on more meds.
Thanks for watching, and I appreciate you as a valuable viewer. And if you liked this segment, you can watch all of the different individual segments or the whole podcast to have a broader understanding on this topic. Just check the links in the description or what you see on the screen right now. I'm Dr. Umer Khan. Looking forward to seeing you again. Thank you.